remove the bear, use the probe. Don't search for the orifices with the bear, particularly the round bear. So don't use bears to localize the canals. Look at here. Our colleague here, he was searching for the canal with the round bear. So you can see here, but the patient was lucky because he did not make a perforation. But look here, too much. He was searching for the canal, but he almost destroyed the tooth. Unfortunately, some patients are unlucky because here, you can see this. Too much. He could not find the canal, so he kept open. Some colleagues, when they could not find the canals, they create canals. You can see here, those are the original canals, and those are perforations. And when he sent it to me, I told him what to do now. Let it rest in peace. That's it. So don't use bears to localize canals. What to use? Sharp probe. Take sharp probe, search the canals with the sharp probe. Just I am searching with my sharp probe. I need good probe to localize the canal. What if I could not find the canals with my sharp probe? What to do if the orifices are covered with the sclerotic dentine? How to remove this sclerotic dentine? Not with bears, but with ultrasonic scaler, regular scaler. All of you have it. Just once I search or try to localize the canals with a probe, I could not find it, I will use ultrasonic scaler. So how to use it? I will use it in a brushing motion, gently. So look here. If you look here, I could not find, this is sclerotic dentine. How to remove it? I will use ultrasonic scaler. So this is ultrasonic scaler. Just I am trying to remove it. Okay, that was removed. This is the sclerotic dentine. Just remove it, and now we can find the canal so we can prepare it. Look here. I opened the pulpy chamber. I could not find any canal. So what to do? I will take ultrasonic scaler and I will go around the periphery, not in the middle, at the peripheries. So I'm trying to remove sclerotic dentine. So let's start mesially. Now I will go at the peripheries. Now I can find the two canals there. I prepare them. Now let's go for the mesials. With the ultrasonic scalers, I will brush in gentle strokes just to remove sclerotic dentine. Now we can find the other two canals. Now I will prepare those all canals here. But with the ultrasonic scalers, I remove the sclerotic dentine like this here. So now it's ready. Look here. The patient was lucky enough because his dentist stopped at the proper time. Otherwise, he would make perforation. He tried to dig. He could not find the canal. So what to do? Stop. Use ultrasonic scaler. You can see here. This is MB1, MB2. So what I do, I use ultrasonic scaler, whatever you like. Now I will go here. We remove the sclerotic dentine. Now I have the MB1, MB2. Now we will prepare them, enlarge them. Then we will fill the 4 canals. Again, I prepared the distal, the mesolingual. I could not find the mesobuccal. How to find it? Ultrasonic scaler. At the periphery, you can see here how we remove the sclerotic dentine with the ultrasonic scaler around. Now we are slowly and gently, we are moving it in a brushing motion. Now we are cutting this sclerotic dentine. Look at this sclerotic dentine here. Now it is removed. You can see here, it's like a stone. We could not do this with the bears. We can do this with the ultrasonic scaler. Now we clean the area and then we continue. Look here, this is the sclerotic dentine. It is removed with the ultrasonic scaler. We discover the MB2 and you can see here the MB2 canals. Always use the ultrasonic scaler at the periphery. Now we localize the orifices. Everything is clear now. We will start irrigation. And to make the story short regarding the irrigation, we consider irrigation as the most important step in endodontics. So we are using 4 solutions for irrigation, using sodium hypochlorite, EDTA, chlorhexidine, and saline. But we need to improve the action of our irrigants. So what to do? All of you, you have ultrasonic scaler. You can attach ultrasonic irrigating tip. You don't have to buy specific device. With the ultrasonic scaler, just buy a mandrel or ultrasonic irrigation tip, attach it, and they found ultrasonic agitation increased the activity of sodium hypochlorite. So what we are doing, an irrigant in conjunction with ultrasonic vibration is associated with the effectiveness to the cleaning. So starting of tomorrow, when you are using irrigant, use ultrasonic activation. When I can use the ultrasonic activation at the end of my preparation, not at the beginning, at the end. Why? I need enough space to enable my ultrasonic tip to vibrate. So enough space should be available at the position. Because of this, should be placed after preparation, at the end, not at the beginning. How deep we will place ultrasonic tip? 2 to 3 millimeters short of the working length. Suppose my working length is 20, I place it at 17 or 18 millimeters. Like this here. When I place my irrigation, this is irrigation tip, then I will take ultrasonic, whatever the brand, attach it to the scaler, place it inside 2 to 3 millimeters short, and activate. When you are activating, you see the bubbles here, it means it acts. It is dissolving the organic materials. So always use it at the end. How many seconds? 1 minute in each canal. I use ultrasonic activation 1 minute in each canal. What is the power? Medium. Medium power. That's it. So I prepare the canal here. At the end, I take ultrasonic activator. I place it inside like this here. You can see the bubbles. 1 minute in each canal. And this activation, it will enable me to clean the canal here. And you can see the results of this after 1 year. So in all my cases, I use activator. And activator, it enables me sometimes to have lateral canals like this, because it helps the irrigant to reach to all root canal system. And let's see the results here after 4 years. Now, I like to share you the protocol I use in my clinic. I use it for more than 20 years, and I'm happy with it. And there are other protocols, but let me share you what I use in my clinic. We have two scenarios for the cases. Either the tooth is vital or the tooth is non-vital and retreatment. If the tooth is vital, I use this protocol. And remember, when we have vital teeth, there are no microorganisms in the deeper level, or what we call E. faecalis. So we don't need chlorhexidine. So my protocol is the following. I use sodium hypochlorite, full concentration, 5.25. I use it during the preparation. Every 3 to 5 minutes, I use 5 cc. Every 3 to 5 minutes, I use 5 cc. So I will irrigate and irrigate and irrigate. Every 3 to 5 minutes, 5 cc for each canal. Then I activate with ultrasonic tip. Now, once I finish this, I will go to the second solution, which is EDTA, ethylene diamine tetraacetic acid. Concentration 17%. We have some schools, they use saline between them. Why? Because they say the sodium hypochloride, EDTA, they interact. So the EDTA will affect the power of sodium hypochlorite. For me, I don't split because I am using sodium for 30 minutes. So now if I use EDTA, that's it. It will not affect a lot. So I will use EDTA. How much? 1 ml in each canal. 1 ml. Then activate with ultrasonic tip for 1 minute. So sodium hypochlorite, then EDTA. Activate for 1 minute in each canal. Next, I flush with sodium hypochlorite. Just flushing. 5 cc for each canal. Just flushing. Next, after flushing, I will use cold saline. Cold saline. 2.5 degree. Why cold saline? We have a study here. They said using cold saline irrigation as a final irrigant reduce the intensity of pain after 24 hours. So it's good to use cold saline. They name it cryotherapy. 24 hours it will release or reduce the pain. So sodium, EDTA, sodium, cold saline, then dry and fill. So sodium, EDTA, sodium, cold saline, dry and fill. This is for the first scenario, which is vital teeth. What about non-vital teeth or retreatment? Non-vital teeth, it means we have deep bacterial infection, or what we call E. faecalis. This E. faecalis, we are using the same protocol. Sodium, activate. EDTA, activate. Flush, cold saline, the same. And at the end, I add chlorhexidine, concentration 2%, time 2 minutes in each canal. So I place chlorhexidine, wait 2 minutes, dry and fill. So my last rinse is chlorhexidine. Why we need chlorhexidine? To kill E. faecalis. So my last rinse is chlorhexidine. So let's repeat this. We will start with sodium hydrochloride, then activate. Then after activation, I will use EDTA, then I will use flush with sodium hypochlorite, then cold saline, then I will go to chlorhexidine. There are several protocols for irrigation. This is what I use in my clinic, and I found it has excellent results. So look at this case here, the same protocol. Sodium, EDTA sodium, cold saline, chlorhexidine, dry and fill. What about lesion? I don't care about lesion because I know inshallah it will heal. So let's see the case after 1 year. We have complete healing. Now, let's go for shaping. And you can use whatever you like. Here I will use the rainbow files from Ramo. But for you, whatever you like. So I need you, when you buy any file, be sure when you buy it to read, this is heat-treated file. So either blue or golden or rose. Heat-treated file. I don't you to recommend you to buy silver files, not heat-treated. Why? Because heat-treated, more flexible, more resistant to fracture. So, heat-treated file. So let's go for shaping, and let me share you some tips regarding the shaping. I always start my preparation with enlargement of the entrance of the canal, which is called flaring the coronal third. So I will take the file. There are always specific files. They are fat, short. It's called the flaring file. So those flaring files. Next, irrigate. You will always hear me say irrigate. Irrigation, irrigation, because it's the most important step. So irrigate with sodium hypochlorite. Next, if you ask me what is the most important step next, it is create a glide path. And to create a glide path, remember this. The most important file in our clinic is K file number 10. K file number 10. And K file number 10, I will take it, pre-curve the K file number 10 like this. And always remember, no file should be placed inside the canal without pre-curving. You should always pre-curve. We are dealing with curved canals. So I will pre-curve K file number 10. Then, once you make pre-curving, it will enable you to go to any curved canal. Just pre-curve. Pre-curve the file. Don't enter with the straight file, pre-curve the file. Now, don't forget, because if you forget, let's see this case. Here, we have curved canal. Our colleague here, he didn't like pre-curving. He liked straight files. So he took the straight file, he tried to place it inside, and he pushed. So he kept pushing, another pushing, then he created his own canal. You can see here. So don't push, always pre-curve the file. Now, the movement. The movement of the file is always what we call watch winding. Quarter forward, quarter backward. Quarter forward, quarter backward. That's it. So this is the movement. Look here. Pre-curve. Place it inside. Look at my finger. This is watch winding. In this way, it will enable me to reach to the end of the canal. This is the watch winding. Next. Now, the next step, when we were in the faculty, when we were young, we took X-ray. Not anymore. Nowadays, we are depending on apex locator. So at this stage here, I will attach my file to apex locator. And when it gives me 0, 0, this is my working length. So this is my apex locator. When it gives me 0, 0, this is my working length. So here we are. 0, 0, it will enable you to reach to the end of the canal. This is 0, 0. Don't stop short. 0, 0. Golbawala, he said, roots with the flush 0, 0 was associated with the highest success rate. So don't stop short. Whatever it takes, remember, 0, 0. Here we have double curve. I will place my file inside and start trying to reach 0, 0. You can see the lesion. Once I reach to the 0, 0, it means I reach to the end of the canal. And when I reach to the end of the canal, this is my feeling. Once I reach to the end of the canal, I feel comfort. This lesion will inshallah heal. Let's see this case after 12 years. We have complete healing. Another thing, once the working length has been established, irrigate. Always irrigate. Sodium hypochlorite. Irrigate. 5 cc irrigation. Now, if you ask me what is the most important factor which influence the healing of periapical lesion, I will tell you the following. This step. It's called apical patency. It means we have to keep foramen open. So what I will do, I will take K file number 10, move it outside the canal to 0.5 to 1 millimeter, like this here. This is the only file which has the right to go outside. Other files inside. This file can go 1 millimeter outside. So this is called apical patency. Apical patency, like this here, will ensure the foramen is not blocked with bacteria. So you have always check the patency, irrigate. Always check patency. And if you underestimate the patency, look at this article. This is in 2011. For this person, Golbawala, he said, patency at the canal terminus significantly increase the odds of success twofolds. This person, he came back again in 2023. You can see here why it failed. Because he did not check patency. If we check the patency, the filling should reach here. And what about the lesion? Of course, once I reach to patency, let's see the result after 3 years, complete healing, patency. Golbawala in 2023, he made a review article and he emphasized this fact. Patency has been identified as the single most important treatment factor contributing to favorable periapical healing outcome. So please, starting of tomorrow, when you go to your clinic and hold your file, remember me and him. Patency. Always check patency. My working link 00 at 20, my K file should go 20.5 or 21 to check patency. Don't stop short. Look here, why it failed? No patency. Reach to the end, let's see the result. After 9 months, we have healing because of patency. So always check patency. Once number 10 file is confirmed, now everything becomes easier and quick. After K file number 10, reach to the end, 00, check patency and irrigate. Now I will enlarge the glide path. How to enlarge the glide path? You have two options. Either to go manually or to go mechanically. And with the mechanic, you can use any brand of the glide path files. Those are from Rainbow. You use whatever you like. But we need glide path files. So I will take the glide path files to the end of the canal, not outside. 20, it means 20. 1 time, 2 times, 3 times. That's it. Then irrigate with sodium hypochlorite. Next, check patency, always. Now, I need 2 minutes more to enlarge the canal. So let's enlarge the canals. Now we enlarge the glide path. Now we will enlarge the canal. And remember, the secret of success is with the limited number of files. So I don't need a lot of files. What I need here to enlarge the canal. So the question is always, doctor, how much I have to enlarge the canal? To which size? Shall I go to 35, 40, 50? For central, how much? For lateral, how much? For lower, how much? Let's make life easier for you. There is always debate. Is it smaller better or larger better? Larger means more irrigation. But larger means more removal of dentine. So more risk of fracture. So how to balance? The prime reason for root canal enlargement is to enable irrigant to reach to the end. So I like this gentleman. He said, apical preparation to size 30 is required to effectively clean root canal. So size 30, enough. That's it. So we will go to size 30. If you look here, I reach to size 30. In most of my cases, 30. Taper 4. That's it. So look here. We have periapical lesion. I will use till 30. 30 file does not mean 30 getaberka. It's a different story. With the getaberka, you check the tagbat. But with the files, reach to 30. And that's it. And let's see the result after 1 year. Here, we have periapical lesion. I will go to 30. And you can see here the sinus after preparation. Let's look here after 6 months. Lesion disappeared. And the sinus disappeared. Now you will ask me, doctor, what about large canals like central incisor, palatal root? How much I have to enlarge? And let's take the answer from Castellucci in his endodontic book. He said, the apical foramen of already wide canal will just have to be cleaned without enlargement. No need to enlarge. For example, look at this case here. This tooth here has a foramen 0.7. How much I have to enlarge? It's 0.7. If I want to, it is already file 70. How much I have to enlarge? No need to enlarge. Just use 30, brush the walls, use sodium hypochlorite. Because what will clean the canal is not the files, it is sodium hypochlorite. So what I'm going to do, I will use 30. Just smooth the walls, remove necrotic materials, use sodium hypochlorite, EDTA, sodium hypochlorite, cold saline, and chlorhexidine. Then, let's fill the canal. And let's see this result after 2 years, and let's see this lesion after 2 years. No more enlargement. 30 is enough. Paper 4 is enough. Don't go larger. Because we, as a dentist, are the most responsible cause for root fracture, because we are enlarging the canals a lot. Sometimes I see in the media, nice root canal treatment, but with big filling. We have a risk of fracture. Don't enlarge. 30 is enough. Now, let's go for shaping protocols. And with shaping protocols, life is easy. Now, I need 3 files only. We have already glide path, large. Now I need 3 files. I need 20. I need 25. I need 30. That's it. No more. No more. I need heat-treated files. Always use heat-treated. Either blue, golden, rose. Here is Rainbow Ultra. It's heat-treated. Whatever you like. Now, what we will do, we will go 20 to the end. 1 time, 2 times, 3 times. Irrigate, check patency. Next, 25 to the end. Irrigate, check patency. Last, 30. Reach to the end and irrigate and check patency. And that's it. Whatever the difficulty of the case, if you follow this protocol, you will have this result. That's it. So endodontics is not ever easier than these days. And cheaper, because the files are cheap, not like the old days. So you can use whatever you like, but in the same protocol. Whatever the case, follow the same protocol till 30 and that's it. Now we reach to obturation. And when we go to obturation, we will always have this question, when to fill? How many visits I need? According to Martin Trupp, he said, 4 scenarios to make single visit, 4 scenarios not to make single visit. So, if you have one of those 4 scenarios, go for single visit. All vital teeth, single visit. Cleaning, shaping, obturation in a single visit. This is the scenario number 1. Scenario number 2. All necrotic teeth with no lesion, no swelling, go for single visit. If we have no lesion and no swelling. Scenario number 3. All cases with periapical lesion but no swelling, like this here, if you can clean shape, dry the canal, go for single visit. If the patient has no swelling, I will go for single visit. Periapical lesion doesn't affect my decision. As long as I have time, can dry the canal, no swelling, go for single visit. And don't worry about the lesion. It will heal, inshallah. Now, the 4th scenario. Look here. A big lesion. Big lesion. So I cleaned, I irrigated. and re-irrigate. And then I dry the canal. And it came dry. What to do next? In the old days, go for non-sitting calcium. Why? The canal is dry. Why I have to go for because we are not sure. Come on. You are the one who did the irrigation. Go ahead and make obturation. Don't wait. If you can finish it today, finish it today. Why to wait? Non-sitting and wait. For what? For psychological purposes. Because we don't want to feel guilty. Come on. Go for single visit. I will go for single visit like this here. Let's fill it. And if you are afraid of healing, let's see this case after 7 years. We have complete healing. Complete healing. Don't worry about single visit. It's reliable. The fourth scenario. When you have a patient with sinus tract, either intraorally or extraorally, it is the best scenario to do single visit. Like this case here. This premolar here, we have a sinus tract. I clean shape. I dry the canal. Next, go for obturation. Don't wait. And let's see this case after 10 days. 10 days, the sinus it disappeared. So don't wait. Look here. This is a cutaneous sinus. So we have a lesion. What I did, cleaning, shaping, sodium hypochlorite, EDTA, sodium hypochlorite, saline chlorhexidine, dry the canal. It came dry. Next, obturation. Doctor, shall I give him antibiotics? No. Shall I make surgery? No. What to do? Nothing. Keep it under observation. And let's see the result after 2 months. 2 months. This sinus tract disappeared. 4 scenarios not to make single visit. All of you will know them. First, cellulitis, swelling. Next, when we have abscess, you could not dry the canal. Third, when you have whipping canal like this, you could not dry the canal. And fourth, if you don't have time. They told us, if you don't have time, don't make a crime. If you don't have time, don't make single visit. Look at those 4 scenarios, 4 cases. When you have complex anatomy like this, when you have calcified canal like this, when you have broken instrument, when you have ledge protocol in the clinic, I will not let the patient open his mouth more than 45 minutes. After that, I am tired. He is tired. We will hate each other. So just stop. Stop. After 45 minutes, stop. Don't continue. That's it. Because if you are working under stress, you will cause further problems. So what to do in this case? Not single visit. You can do them in multiple visits. Castellucci, he make single visit for a tooth. Let's make single visit for a root. That means, and you can find him in his book. He said, if you could not do single visit for the tooth, let's make single visit for a root, which means, in his book here, he said, it is mistake to jump from one canal to another with the same instrument. And the canal should always be prepared individually. And he said, never introduce a file into root canal if you are not 100% sure that the specific canal will be completely. It means what? If I am working with the lower molar and it is difficult, why not to go for the distal root, make a cleaning, shaping, obturation, finish it. Next time we will go for the mesial root. And this is what I do in my clinic. So let's see here. Here we have this complicated method. So today I will go with the distal route. I have 40 minutes. So what I'm going to do, anesthesia, access cavity. I will go to the distal route. I will make a cleaning, shaping, irrigation, and obturation. And you can place in the mesial route cotton pellet. Don't touch it. Don't touch it. I will not touch it. You remember in the faculty they told us, go for the mesial, remove pulp and the distal, and next time you will forget where you reach and it will be contaminated. Nowadays, we don't do this. Just focus on one route, finish it, fill it. Next time, I will go for the second one. So what I am doing here, distal route, I filled it. Then after, in the second visit, after how many days? After 1 day, I gave him another appointment. I will go to the mesial route. I will make cleaning, shaving, and obturation. So divide the work. Focus on one route instead of one route. If I can finish it completely, okay. If not, focus on one route. Let's see this case here. I have open apex and I have calcified canal. It is difficult. So what today I will do? I will go to the mesial route, cleaning, shaping, obturation. Distal route, I will follow the same protocol with irrigation slowly and gently, and I will give the patient another appointment. After 4 days, I will fill it with MTA. So divide the work. Look here, this is difficult. I could not finish everything today. So what I will do, distal route, I will make cleaning, shaving, and obturation. Now I'm tired. I will let the patient go home and I tell them after 5 days, when I miss you, you come back. So he came back after 5 days. Now I will make the mesial route, cleaning, shaving, and obturation. So divide the work here. We have a ledge and blockage. So what I'm going to do, I will make the distal route here. Now after 1 week, I told the patient come back. Then I will go to this one after 5 days, and now we finish it. And if you think this is not successful, let's see this case after 2 years. 2 years. So,
2 years.
if you could not finish the whole tooth in one visit, divide the work. You can focus on one route, next time on the other route. Now, how to fill? There are more than 20 techniques for obturation. Nowadays, I use 1 or 2. Make it less. And the easiest one for all of you, go for the following technique. I will choose the master cone. This is the master cone. Always choose 4% taper. Why 4% taper with a strong tuck back? It guarantees the tuck back is at the apical part. So I will take, I prepare the canal till 30. This is my master cone. No tuck back. Let's take 35. Strong tuck back. So I will use 35. Now I will take X-ray. It's very important to take X-ray here to verify we reach to the end. Next, after master cone and the X-ray, now I will dry the canal with paper balls. Now we are ready. We need 1 minute to fill the canals. With what? With bioceramic sealer. What brand? Whatever you like. Whatever you like. So I will use this, but whatever you like, it's fine. What I will do, why bioceramic sealer? Bioceramic sealer is biocompatible and it includes zirconia and aluminum. It has many characteristics like antibacterial, biocompatible, stable, it bonds to dentine, it will not, is not absorbable and easy to use. So it needs 4 hours to become dry. So here it's the master cone with ready. And let's see how to use bioceramic sealer. Very easy and very simple. It doesn't need expensive material or expensive devices. It doesn't need heat. It's cold technique. So let's see. I want to fill the canal with the bioceramic sealer. Master cone. We check the master cone. Now we have strong tug back. Now how we will fill with the bioceramic sealer? This is bioceramic sealer. I will take a file. Suppose it's 20. I will place the file on 20 and place it in the dispenser. This is bioceramic sealer. Now I will place the bioceramic sealer inside the canal. With the file, counterclockwise, just with your hand. Now the canal is filled with bioceramic sealer. Now I want additional bioceramic sealer. I will take getaperca, insert it into the bioceramic sealer again. You can see there. This is the bioceramic sealer in the other canal. Now I will take the getaperca and place bioceramic sealer around it, like this here, and then I will place it inside the canal. Then I will take any hot device, any hot instrument. You can use light to make it hot. Then cut the getaperca till the orifice. Can we attach charger to this? Okay. And now it's ready. Ready, and that's it. It takes 1 minute. And that's it. It's the easiest technique. Here, it is filled with bioceramic sealer. Now, let's go for endodontic challenges. And when we talk about challenges, according to American Association of Endodontics, we have 3 levels of difficulty in our clinics. Either we have one type of anatomy, it's called class 4. Let me remind you, according to Wynn, he says, if we have one orifice, one foramen, it's type 1. 2 orifices, 1 foramen, type 2. 2 orifices, 2 foramen, type 3. And the most difficult one is type 4. Type 4, 1 orifice, split, and go to 2 foramen. And this is complicated because how we fill it, we can prepare it, but how to fill it? So let me share you the way to fill it. In the floor of the pulpit chamber, we can detect only single orifice, like this here. Now, the same way of preparation, I will use the flaring file, enlarge the entrance, then working length is determined, 0, 0. Then prepare the canal with the rotary file. Preparation is easy, but the obturation is difficult. Now, how to fill it? Because if I use bioceramic or any type, the sealer will enter inside one canal and block it. So how to fill it? I will place K file number 10 inside one canal and getaperca in the other canal. Then I will fill with any device, heated device. I will fill the canal, the first canal. Then I will remove the file and place the getaberka here. And now I will fill the other canal. Then you can see here. So the file, K file, it preserves the space for the new getaberka. Look here, the same way. We have one orifice split into two. So I will place one getaberka inside and one file there. Then, you can see here, then I will fill the canal. Sometimes it's so complicated here. One orifice split into two canals. The same way, I will place one file and one getaberka. And then this is the way of operation. This is very interesting. I will place one file here. This is the entrance. Two canals. One getaberka, the other. If I place them together, they will not enter. So what I will do, I will place one file and one getaberka. Then I will fill the first one and the other one, and this will be the final result. This is type 4 for wing classification. Let's go for conclusion. And I found the best conclusions to share you is this article. It's a very important article released in 2023. And this article, it showed us 10 procedural factors affecting healing. So I like you to remind them, and you can find this article in the internet. It's free. So they said, if you are using rubber dam, it will improve the outcome of endodontic treatment. So one of those factors, using rubber dam. Using rubber dam could provide significantly high survival rate. The success rate of a treatment using rubber dam was 77% if you are using rubber dam. So the first factor, use rubber dam. Another factor, here, significantly higher periapical healing with the rubber dam. Access cavity. If you make proper access cavity, it will allow easy accessibility and maintain tooth structure. So don't make wide access cavity, make it conservative access cavity. What about canal's location? They said the overall prevalence of apical periodontitis was 90%. Anytime you miss a canal, there is a chance of having a lesion, 90%. 90%. Remember this. Don't leave any lesion, any missed canal. Look here. So don't miss the canals because we have high prevalence of lesion. And as I told you, maxillary molars with a missed canal were 3 times more likely to have a lesion. Like this one here. Negotiating canal to terminus. They said, if you reach 0-0, highest success rate. Like this one here, 0-0, highest success rate. This is very important article. They said, every 1 millimeter short inside the canal, increase the failure rate 12%. Every 1 millimeter. So don't miss any 1 millimeter. Very important. You can see here, 1 millimeter cause failure. Reach to the end. You can see the result after 2 years. Here, although it reached nearly to the end but have big lesion, if I reach to the end of the canal, you can see the lesion disappear after 1 year. Patency. If you have one thing to remember from this session, remember patency. Patency. Patency, it will increase the success twofold, 2 times. Patency at canal terminus, the only significant prognostic factor. And out of 10 factors, patency is number 1. You can see patency. Canal enlargement, size 30, no more. Go for size 30, enough. Another thing, they said over enlargement is unnecessary. Don't go for 40 or 50. Apical enlargement to 30 is more than sufficient. Enough is enough. Disinfection with sodium hydrochloride and EDTA, very interesting. 1 minute of EDTA is efficient for smear layer removal. So go for 1 minute EDTA. And they said, and interesting, irrigation with EDTA improved periapical healing 1.3 to 2.3, double. So use EDTA. You can see the lateral canal here and the heel. Single or multiple visits, no difference. They found there is no significant difference in healing of lesion between single and multiple visits. So if you can go for single visit, go for single visit. It's called high by patients. See him 1 time, that's it. I don't like to see patients frequently in my clinic, the same one. To finish it, that's it. We are not like orthodontists. The relation like Christian marriage. But here, 1 time, that's it. So here, if I can dry the canal, there is no swelling, go for single visit. If you are afraid of lesion, let's see this lesion after 7 years. What about root filling? And if it is short or overfilling? Let's see here. We love to be adequate, 0-0. And according to the study, it is best to avoid extrusion of root canal filling. Remember this, it is better not to have overfilling. But what if we have overfilling? Like this case here. He said here, it has been accepted that the apical extent of root canal filling seems to have no correlation with the treatment failure, provided infection is absent. I don't recommend overfilling, but the most important part is the disinfection. If accidentally you have overfilling, you should feel guilty, but don't go further than this. So let's see here. According to this gentleman, he said, disease associated with overfilling is caused by infection inside the root canal, not the overfilling itself. So look here. I like to show you my success and my unpleasant cases. Look this here. I made root canal treatment. Oops! Distally I have overfilling. It's ugly. It's not good. I learned from my mistakes. But what to do? Nothing. Keep it under observation. And let's see what will happen after 6 years. Cataberca is shrinking, and healing occurs. Why? I have good irrigation. So overfilling did not affect, I don't ask you to make overfilling, but if it happens, keep it under observation. Look at this case here. This patient, he was referred to me from endodontist. He told me, doctor, we made root canal treatment. I have overfilling. After 1 year, he came with a swelling. What to do? Shall I go for apical surgery? Why he has this swelling? I told him, according to what we knew now, the lesion is due to bacteria inside the canal, not overfilling. So what I'm suggesting, don't send him to surgeon. Redo the root canal treatment. He told me, doctor, I'm not so convinced. I prefer surgery. So I told him, I'm fully convinced I will go for retreatment. And let's see what will happen. So I will go for retreatment. What about the cataberca outside? Nothing. Nothing. Keep it under observation. Let me show you this case after 6 years. It's almost the same. Let me show you this. This is yesterday, 2 days before. And I brought it here to you to see it. While we are a human being, we have mistakes. We are not ideal. I show you my good cases, my ugly cases. So when I did root canal treatment, oops, cataberca went out. So I wish at that time to disappear. But it happened. Sometimes they ask me, doctor, you have all sophisticated devices, microscope, CBC. Why it occurred? Because we are human. It happens. But if it happens, do 2 things. First, learn from your mistakes. Next time, I will check my tug bag, and I have to be sure my tug bag is good. Next, don't do surgery. Just wait and see. So, let's wait and see. Let's see this patient after 12 years. You can see? After 12 years. Let's go to the extreme. Let's see this case. And with this case, I will finish. This patient, he had root canal treatment, like root canal treatment. So his dentist, he broke 1 file, 2 files. He made the distal canal, and he did not forget to make a crown. He was so brave to make a crown. 1 year later, the patient came back with a swelling. So his dentist, he told him, you know, your body did not accept the filling, so let's go for extraction and implant. The patient came to me and asked me, can you do anything? I told him, you have 2 options. The first one, to go for apical surgery. The second one, now we understand the problem is not with the file outside, the problem is with the bacteria inside. So let me try to make good root canal treatment, and let's see what will happen. Okay. So I tried to bypass. While I am bypassing, what happened? The broken instrument was pushed outside. So instead of 3 millimeter out, now we have 9 millimeter out. So how I will tell the patient, now it's the time to extract. I spend a lot of time convincing him with the bacteria inside. Now I will tell him. So what I told him, you know, let's hope your body will accept this. And don't go to any dentist. And we will keep it under observation. And let's pray. This is the best thing to do. And go for a crown. Because if I leave it without a crown, it will break. The patient went out, and I feel, come on, what will happen to this patient? I was expecting after 1 day he will phone me. For 4 days I was expecting to phone me, no one took. So either he died or anything happened to him. For years, I didn't see a patient. And one day he came to my clinic. And when he came, I remembered him. So he has a swelling. So I am thinking, is this the same tooth or not the same tooth? So I was wondering. He sit on the chair and he pointed to another side.
Oh.
So I told him, let's take X-ray for the one which we did. Is it still there or do you have implant? No, doctor, it's still there and I'm proud you did it for me. Proud, okay. So let's see the X-ray after 10 years. So, alhamdulillah, it's not luck, it's Allah sometimes make your life easier. I wish you all the best. Thank you for everything.